Welcome back, everybody. We are turning to the regulatory mechanisms for distributing and studying medical countermeasures in an emergency, and several commission members suggested, as did many people who presented to us previously, how important it is that there be preparedness. And we'll begin with a brief presentation from the Commission's Executive Director, who's also an expert bioethicist in her own right, Dr. Lisa M. Lee, who will review for us what are the regulatory mechanisms that exist for distributing and studying medical countermeasures in an emergency. So Lisa, why don't you take it away for us?
Terrific, thank you all. I think a couple of important things as we discuss how we'll go about distributing and studying medical countermeasures in the event of an event include that distribution for treatment and distribution for research are different things, as we've discussed. In the case of an event, we'll likely be most concerned, obviously, with treatment and making sure that we manage the event. But we also will have an opportunity, as we've been discussing this morning and other times, to do some research that otherwise we would not be able to do, and some of that will be observational, obviously. And there are certain mechanisms that the FDA has authorized for us to enable unapproved products to be studied and used for treatment in an emergency. So there are a couple of regulatory mechanisms. We've talked about these briefly with some other folks who've talked to the Commission before. Those two things for off-label or use of approved medical products or things that are virtually unapproved at this point. These two mechanisms being emergency use authorizations, or EUAs, and investigational new drug applications, or I'll call those INDs. These two tools allow for promising but unapproved pharmaceuticals to be used in an emergency. The first one I'll talk about are the EUAs, or the emergency use authorizations. The key with this one, as I mentioned, are the promising but unapproved pharmaceuticals, one piece of the definition, and the other is the public health emergency. So two things need to be defined here. What is a promising but unapproved pharmaceutical? There has to be some scientific evidence that indicates the product might be effective against either a serious or a life-threatening agent. So some data have to be available. This can't be a brand new biologic or a brand new drug. There has to be some known or potential benefits that are outweighing the known or potential risks. And ultimately, no other alternative. It's got to be our only option. In terms of the definition of a public health emergency, this has to be something that has been declared by the Secretary of Health and Human Services. And it involves an agent or a pathogen that has the potential to cause serious or life-threatening condition. So the situation would be dire if we were in a situation to use one of these tools. Now, in terms of use during a public health emergency, the EUA allows us to use a product, not to study a product, but to use a product. So this is not a research tool. It does involve some pre-planning, and actually, in order to use it, we have to know what we'd be doing in the case of events. So the FDA allows for what they call pre-EUA planning. Most EUAs are in the pre-EUA stage because we're not most of the time in an event, so most of the EUAs that exist are in pre-planning. And this happens where an authorization has happened far before an emergency is declared. The FDA can take time to review the situation and plans before an event. The clinical use then is subject of this event, of this agent, is drug or biologic is subject to strict limits. It does use a clinical consent paradigm, however. There's not an IRB review, there's not a research protocol, as I mentioned. The goal is to really give timely access to a product during an emergency. As I mentioned, it's not a research tool, so there are not research protections under an emergency use authorization. The use is the key word there. And limited data collection is allowed. There is the provision for some basic data collection so we can observe what's happening during this limited use. But it's not at all near the research perspective. It also, so if we think about the use specifically to the anthrax situation, an EUA would be something we could use in an adult because we do have some information, some data on safety and efficacy for adults. So an FDA pre-EUA authorization for use of AVA as a post-exposure prophylaxis in adults does exist. And those data that we have for adults come from the pre-exposure AVA use we have for many families and first responders as well as military. So we do have data. Those data support the EUA for adults. For children, as we've talked about, no data exists for AVA. So we can't use an EUA for AVA for children. So what do we do for kids in the case of an event? We turn to the investigational new drug application, the IND, the other tool. So that tool, the IND, allows for the commencement of clinical testing for an unapproved drug or biological product. So no testing done, we have no information. This IND allows for us to begin that. Tough to begin that in a situation where we're in a stressful or potentially chaotic situation in an emergency. But there are three kinds of INDs. One is an investigator IND, and this is in your normal situation, just interested in a product, want to investigate its usefulness clinically. A researcher would initiate and conduct an investigation of a new drug or a vaccine. A treatment IND is an IND that allows for the use of a promising drug or biologic for treatment with patients that are not in the trials that an investigator is doing. And then finally, there's the emergency use IND, and this is a tool that allows for individual patients in extenuating circumstances to get a hold of an investigational drug. We're not going to talk a lot about that, but we will talk about the emergency use of a treatment IND. So just so we get clarify around the language, we're talking about the emergency use of a treatment IND. So in a public health emergency, the requirements for the emergency use of a treatment IND, which we would have to do in terms of a drug with no data associated with it yet. It would require a drug intended to, again, treat a serious or life-threatening condition. The drug would need to be under investigation or in trials that are completed. So a treatment IND is usually paired with an investigator IND. They're often called a nested treatment IND. So an investigator would have a trial that they would be doing for a new drug, and then the treatment IND would allow the drug to be used more broadly, not just for the people in the clinical trial, but also other places. So the sponsor would be actively, that means the person who's doing the trials would be actively pursuing approval of this drug or biologic, and then the potential benefits, again, outweigh the risks, just like in an EUA. And again, no satisfactory alternatives available. So again, both of these tools for a situation where we don't have any other options. Specifically for a public health emergency with anthrax, again, with children in the absence of any pediatric data, an IND is a feasible mechanism for delivering AVA to exposed children. Coupled with this investigator IND, data could be collected to inform future use for potentially using an EUA if we needed to use AVA in a future situation. An IND in this situation would be under a research protection paradigm. Unlike the EUA for adults, which is a clinical paradigm, this would be research protections paradigm. Things like an IRB review using written parental permission and meaningful child assent. So to summarize in terms of the mechanisms and how they would be used in terms of an emergency, we would have for adults, because data already exists for pre-exposure prophylaxis, we could use the EUA in post-exposure prophylaxis for adults under this clinical consent paradigm. And for children, the investigator and treatment IND under the research protection paradigm. So just to summarize then, we have these two tools, one very useful for adults for the use, also allows us to collect a small amount of data, and the investigator and treatment IND coupled to allow us to use the AVA for children during an attack. So I'll take questions if anyone has any clarifying.
Yeah, and we'll take questions on clarifying this, and then I'll summarize, and we'll get into how we are proposing as a commission to use these mechanisms post-event.
Perfect.
Lonnie.
Thank you, Lisa.
Sure.
Help me understand, is AVA considered in children, it would fall under the research protection paradigm, correct?
If used under an IND,
IND.
yes.
An IND would be used in an emergency situation.
For children, yes.
So that would mean that an IRB would have to be convened and review the protocol prior to AVA being given to children.
The FDA has some latitude in the emergency use. They can do, there is also, just like with the EUA, there's a pre-IND time where the FDA can review the protocol, can work with an IRB to do some review of that prior to an event. The piece that logistically, I think what you're getting at is what are the logistics for getting this all done and quickly, because in the situation of an attack, while antibiotics would need to be delivered within 48 hours or so, and the AVA would actually need to be delivered within days, 10 to 14 days. So in terms of the lag for an IRB, that would be a big problem. So the FDA has discretion, and both in terms of pre-approvals, the pre-IND, and also in terms of potentially waiving that or making an exception for IRB for a particular situation.
I say that couched with the comment made by Christine that the government does plan to give children AVA drugs if, okay.
Mm-hmm.
Christine?
So maybe I can ask a question about that. My understanding was that a pre-review and approval of a treatment IND for AVA in children was already in place.
It exists at CDC. They are the holders of that. The pre-IND has been, CDC is the holder of that, yes.
Nelson.
Yeah, so I think that's essentially what I was driving at. I've been reading the 2009 CDC guidelines.
Yes. Mm-hmm.
It says the use of AVA in children is not contraindicated in a post-event setting that poses a high risk for exposure to aerosolized B. anthracis spores. During such an event, public health authorities will determine whether, under the existing IND protocol, to vaccinate children aged 0 to 17 under this IND protocol, 3 doses of vaccine, et cetera. So, so I guess in your view, that this would be an extension of that existing IND.
Correct.
That could be done relatively efficiently.
Yes, yes,
Okay.
yes.
So I think that's important to clarify, because it doesn't really, this clarifies and substantiates some of the discussion we had earlier about the fact that when it's distilled to practice post-event, you're very likely to see children offered both vaccine and drugs.
Yes.
Okay.
In fact, ACIP recommended that that be done on a case-by-case basis, but HHS has, has said that they will make vaccine available to children as well as to adults.
Dan.
Just another clarification about the logistics. If I understood you correctly, the children's parents would need to sign an IRB-approved consent form for each child who will get this. So that it's just another issue out there in the field. But okay.
And it's an excellent point. In terms of the concerns of the folks in public health response, there are concerns about parents, adults getting this through an EUA, which is a clinical consent, and just yes, please, give me the vaccine, and their children who might not be present with them at the time of an attack, needing to have a written consent, parental consent to have their child immunized. So, yeah, the logistics are not a breeze.
Raju.
A quick clarification question. So let's assume that I'm, internist with specialty in ID, and I'm especially interested in, AVA. I want to conduct a physician-initiated IND to study the immunogenicity of AVA, and I would apply to FDA. I would be denied.
Well, I'm not FDA, so I'm not going to make
But
that.
I mean, according to based on the rules that you just talked about. You talked about post-event. I'm talking about today.
Oh, pre-event. Well, I mean, part of our question is, you mean for children?
For children.
Yeah, part of the question facing you all, the commission, is should these types of studies be allowed to go forward? We don't have a protocol. We're not even, at the point to have a protocol. So, we're going to help answer the question to the secretary. What are the ethical considerations that need to be, out there before a protocol could even be given? Yeah, to even consider it at the FDA or any, HHS or governmental funding for such a thing.
Other questions for Lisa? Lisa, stay up here
Oh, okay.
for this.
Sure, absolutely.
And you were right the first time you said our, deliberations.
Well, thanks.
You've been very extraordinarily helpful, instrumental, and extremely knowledgeable in helping us move our own deliberations forward. So let me just summarize, as Lisa explained, and then move it the step further to where we are in our deliberations and open it up. And I'll ask Anita to say more. I'm going to do a very high-level summary. So the FDA currently interprets the provisions of the EUA, the Emergency Use Authorization Mechanism, to require at least some data from pediatric testing before an EUA can be issued for pediatric medical countermeasure use in an emergency. It is preferable, we think, to use the EUA mechanism when data are available to characterize the intervention in pediatric populations. Because children react to drugs and vaccines differently from adults, the heightened safeguards of pediatric research protections are appropriate for an intervention that is completely uncharacterized in children. It also, and therefore makes sense to us, to endorse the FDA's approach to the use of INDs, or investigational new drugs. That is, when there are no existing data on the administration of a medical countermeasure to children, and it will be made available to children in an emergency. It should be provided under a treatment IND. That's to ensure that rigorous pediatric research protections apply. And at the same time, we're saying there are and should be advanced preparations to expedite this. Such protections include, for example, independent review by a local IRB in the case of an emergency, expedited review. When a medical countermeasure is distributed broadly to children using a treatment IND, it is also essential to conduct a concurrent small-scale study under an investigator IND to obtain data that can potentially be used to support an EUA for pediatric use of the medical countermeasure in a future event. So planning for post-event research is also essential, and to expedite post-event research and ensure the availability of appropriate medical countermeasures for children, a pre-IND consultation and approval should be put in place before an event. And that's on a, I think, a a good summary of where we as a commission propose, where we think we stand now with regard to recommending preparation, full preparation in the case of an emergency. And I'm going to ask Anita to take it from there, because Anita's been very involved, as other members of the commission have, in these deliberations.
Thank you, Amy. As you said this morning, we all hope that the events never unfold that would give rise to the need to play out the post-event pediatric medical countermeasure scenario that we're responding to, we're poised to make recommendations about. But we have to be realistic. We can't hope that our government turn a blind eye. As a country, we have to be prepared. This morning, both Nelson and Lonnie emphasized that we need to be ready to carefully deploy the appropriate and ethical medical countermeasures to everybody who stands to benefit, including children. So as I understand where our deliberations have led us, we are poised to recommend a set of carefully devised post-event emergency responses that kick in when children have been exposed to relevant biohazards, and also when there is an imminent threat that they might be exposed. I think about it in terms of there being substantial likelihood that exposure will take place. That's using my tort law discourse there, substantially certain to occur. And our aim is to always be, in our recommendations, sensitive to the demands of beneficence and respect for persons, parental and individual autonomy, allocational justice, and deliberative democracy through both accountability and also public engagement. So here's what I think we're prepared to endorse. First of all, I think we're prepared to endorse swift delivery of therapeutic medical countermeasures to exposed and imminently exposed children, whether they've been tested earlier or whether they've been pre-tested in children pre-event. That we do think that it could be ethically appropriate to deliver these countermeasures. But we also believe that there must be promptly initiated both data collection, observational, investigational type research aimed at better understanding such concerns as safety, immunogenicity, efficacy, and dosing to the extent consistent with the child's health and recovery. We do think that children may benefit directly from such research, which renders it ethical in a way that it would not be ethical prior to the event. We also seem to agree that post-event research should be constrained by existing regulations having to do with limiting research to minimal risk or minor increase over minimal risk in children who won't directly benefit from the research. So I'm going to just say a little bit more about both of these categories, the testing and the delivery of the countermeasures. But first, as to research, I think what we're saying is that research is ethically required post-event, not just okay. We're recommending that there be follow-up research to determine the effects of delivering a medical countermeasure that has not been previously tested on children. How does it work? How safe is it? How effective is it? We want to look at those kinds of questions to the extent that we can. It's going to be sort of both prudent and ethically necessary to take stock after the deployment of countermeasures. And one issue that I think our group might want to discuss a little bit more today is whether passive surveillance based on self-reporting research is all that's necessary in the event of just delivering a countermeasure that's not been tested before on children. Do all we need to do just wait and see what happens and based on self-reports, or should there be some research protocols that are developed to more systematically gauge the effects of the countermeasure? I think we're also recommending, again, research, both surveillance type and investigational research post-event, and that if decision is made to treat children with a drug that's not been tested, we should be mindful of what kinds of protocols would be ethically required and permitted in these contexts. There are choices to be made about whether nested or independent type investigational clinical trial research is best from a scientific point of view, and I leave my scientific colleagues to comment on that. Do we want to have the kind of IND nested research happen, or do we have some other kind of research happening on the side in addition to that? To best protect children in accord with traditional ethical constraints, we're endorsing deployment of untested medical countermeasures, but within a framework of a non-research FDA IND. Lisa just nicely described that a kind of paradigm of investigation and treatment IND, which is very protective. This kind of research would be, except in a very, very, very emergent situation, would be protected by an IRB approval. There would be assent or consent involved. There would be pre-planning consults with pre-approval, hopefully, for this type of research. And these kind of protections, the pre-consult, the IRB, the consent, assent, would mean that this kind of research would meet the ethical demands that we think are important in this context, more so than the emergency use authority, which not only would not be appropriate because the drugs have not been tested on children, but also don't come with any kind of research-based add-ons and the IRB approval. So, okay, so applying our recommendations to, or framework to the anthrax vaccine, we're assuming that post-event children would be administered the vaccine and antibiotics, even if the vaccine had not been yet tested or thoroughly tested. And our approach, I believe, endorses such a possibility, but recommends that there be ethical monitoring in the form of ethically designed follow-up studies for data collection, and also any other investigation or treatment IND-based research that could be done within the prescribed paradigm. So all of this said, I am left wondering about some of the concerns raised earlier about how quickly can we deploy all of this. Less than a month, less than a week. Will there be political pressure to put aside some of the protections that we've ethically recommended? I hope not. But I do think that we need to talk about the what specific kinds of research we are thinking might be done that would be beneficial in the context of an investigation and treatment IRD, and ensure that we think those kinds of research, the ones that scientists would say would be useful, would also be ethical. But it seems to me that with IRB approval, this framework of the investigational treatment and IND paradigm would work quite well and would be ethically sound. And I hope we never get to the point of trying to set aside ethical guidelines in order to respond to an emergency in a somewhat rash manner. So I will stop there.
Thank you, Nita. That was a really excellent summary of post-event process and substance to meet ethical principles, would satisfy those in a post-event setting. We say that it has not been tested in children, and that is correct. We also, just to remind us ourselves and anyone listening, we also recommend, or we're poised to recommend, that there be age de-escalation testing consistent with minimal risk research with children, and that could start anytime and get, at least for older children, some possible data. But everybody who has spoken to us agrees that there would be the need, and we agree with this, there would be the need, still the need for research testing under ethical standards in the case of an event. With that, let's open it up for any discussion, questions, comments. Dan, why don't you begin?
Yeah, but one thing that's sort of concerning me as we move to talk more about post-event testing is that I'm not sure our deliberations so far have given sufficient attention to the sort of general literature on the ethics of disaster medicine. And I think that we're sort of thinking of this as sort of our nice research protocol and all of the sort of clean ethics we'd like to see with it. But I've said before, I was at St. Vincent's Hospital when several hundred very self-important NBC employees descended on the emergency room with within hours of a cutaneous exposure. I think that's nothing in comparison to the kind of widespread panic and logistical difficulties that will ensue in the event of the kind of disaster we're thinking about. Questions of the potential for overwhelming resources, even clinically, to distribute the drugs, the panic, etc., need for triage, possibly if we have shortages, and I think we have to be thinking about that as we're framing any kind of research protocol. Certainly we can talk about preparedness. We've got to talk about preparedness from a public health perspective and about research logistics. But I also think that we ought to be careful to think about as clear and simple research protocols as we could imagine if there's going to be anything in this kind of a setting, because the simple fact is the kinds of things we tend to think about in the clinical research arena are not going to actually be feasible in this kind of realistic setting. And I just think that we've got to be more attentive to those kinds of concerns than I've heard in our deliberations.
Nelson?
So just to answer, or at least to offer one answer to a question that Anita posed to us, which is the question of a passive survey versus maybe a more active surveillance of those who have been vaccinated. I think I would come down pretty definitively on the latter. I think that this will be a situation where you're going to be taking the risk of going off a bit into the scientific unknown to vaccinate children. I think that it would be ethically important for us to do the best that we could to ensure that there is ongoing observation of safety in those circumstances, because we may learn something that might cause an actionable change to practice in the case of doing those kinds of studies. So I would feel very strongly about, in a post-event situation, to actually do active monitoring and not a passive reporting system in a subset of individuals.
Steve?
Yes, I was going to make a very similar point. I agree with that. We all know that the awareness of potential adverse events can create false alarms that are very common. And one question that I have with respect to an active system and where a treatment IND and an investigator IND opportunity may, where that limit is an active surveillance event is not a small nested study, but suggests a larger study that potentially might also include people who opt out but are in the high-risk zone as a control population. And how do we think about those very practical issues that would be involved in an active surveillance concept?
Lisa, do you want to take a stab? That's a really important question for
Sure.
us to consider.
I think that the issue around studying that in an active monitoring kind of way for people under the treatment IND. And remember that the treatment IND is for people not involved in the trials of the drug. So these are, remember, we don't know much about the drug to start with. So the people in the under the investigational IND are people who are, in the clinical trials of, does this drug do what it's supposed to do? What's the right dose, et cetera, all the phase 1 through 3 clinical trials. Those under the treatment IND are people who aren't in those clinical trials, but who, in the case of an emergent event, could benefit if there's no other option. Included in that treatment IND could be something around, as we're discussing, these active monitoring. And if the active monitoring would need some comparison group, that could be something I'm sure that could be built in, whether it's, they probably wouldn't be people under the treatment IND, but we could, like they do lots of vaccine research for adverse events, look at an appropriate comparison group. So, but I think that there is absolutely a way to look at that and to do that. And there's lots of vaccine researchers that do this kind of work that could design a study that could get to that.
Christine? Raju?
And I want to follow up on Nelson and Steve's comments, and I want to ask a very pointed question. And so Anita said that, you know, that the population that's been exposed, that it's ethically imperative that they should be studied. I think that's good. And also the point that is made is that the kinds of studies should be just not passive studies, but active studies to really understand that. And the question that I have is that those active studies might include the kinds of interventions that would be currently be considered to be greater than minimal risk, or significantly greater than minimal risks. And so one of the, you know, that we have said that under no circumstances would children be exposed to any types of research studies that would involve, you know, greater than minimal risk, or, you know, so the definitions of that have to be clear, that the, you know, what are the kinds of things that might be permissible under those circumstances might not be included in the current set of guidelines for what is acceptable and what's not acceptable.
Do you want to respond?
So in the case of a post-event situation where there is the possibility of benefit, direct benefit, the idea of greater than minimal risk changes. So what we were talking about in terms of limiting or capping at a minor increase over minimal risk is for the pre-event situation where there is no offsetting direct benefit. We're talking now about a post-event situation where if we get in a situation where there might be something, as you said, it's not necessarily that the actual, let's say in this case it's a vaccine, the vaccine might not be greater than minimal risk, but the other observational things, if you have to do many blood draws or you have to do some other research-related intervention that would be considered greater than minimal risk, that could happen, and that's, you know, parsing out the risk. So that if the research risk is greater than minimal, that could be allowable. I mean, we'd have to see that, you know, we're not the people deliberating the protocol, but an IRB would have to look at that. In the case where there is the possibility of direct benefit or the idea that there is, you know, that the child themselves would benefit. Now, whether that study would be designed in an event of a, you know, a bioterror attack remains to be seen, but there is that possibility when there is direct benefit to be had.
Can I just say, I think, I understand that, but the question for us is to whether that should be articulated in our report.
Yes, and our plan at the moment is to articulate that. The situation changes. There are still ethical guidelines, but they have a different implication when children stand to directly benefit from research. And then you want to impose no more than necessary risk. The risk has to be proportionate to the benefit, and you still want the consent, informed consent of parents and consent, if possible, of children. But there is a direct benefit to the child, and that makes all the difference. And we absolutely will make sure that we articulate that in the report. I see Anita.
I just want to clarify that. Would this be accurate just to say simply that post-event research should still ethically be constrained by the existing regs 405, 406, 407? It's just that it have different implications in the context of whether it's direct benefit and the risk is proportionate. So we're still within that same framework, but now we might be allowed to do some things which we wouldn't have been allowed to do pre-event, right?
Correct, absolutely correct.
Okay.
The ethical principles are constant. Their implications change for when a research subject who is a child stands to benefit versus when a research subject who is a child does not stand to benefit. They also change with adults, but the very big difference, extraordinarily big difference between adults and children is children can't themselves give their informed consent. So it is incumbent on us to add protections to prevent exploitation and any other injustices to the child. Jim?
Just a very quick point. I know that it's a little bit of aside of what you just said, Anita, but yes, under those circumstances, as we've talked in the past, we would imagine more risk. I would hope that when we document this in a report, we wouldn't talk about being allowed to take more risk, but rather reluctantly having to accept more risk by pursuing these kinds of protocols.
Nita.
I have just a couple of maybe definitional questions given the conversation that we're having. So the first one is the stand to benefit language. So especially with the conversation we're having earlier about exactly how you would define post-events and who is included within post-events, is the idea of stand to benefit now any child who might potentially be exposed to anthrax? And if we were imagining the scenario that Raju had outlined, which is, there's an event in Boston, but we think about it as being potentially imminent across the country. And does that mean that the stand to benefit applies broadly such that the types of risks that you could expose a child to post that event would apply to everyone? And then related is, as we're talking about consent, I know we are going to and have talked a bit about the framework for consent and how that's different in the post-event framework. But how do we safeguard that in the post-event framework where there's fear because an attack has already occurred, the likelihood of being able to obtain, a more objective type of consent is diminished because of the concern, and so the reasonable parent standard may change under the circumstances of an event having already occurred. So.
Do you want to do both? I mean, I would turn to you for the second part of it, but feel free to do the first part too if you like. I'll take the first. Just it's important that imminent not become potentially imminent, as you put it. Imminent is imminent, and if it's not imminent, but we live in a potentially imminent world where many things are potentially imminent. So potentially imminent isn't enough. It has to be imminent. And similarly with might benefit, that's just too vague. We have to keep the standards that there is, in the case of, we're talking about post-event, there needs to be knowledge that the children who are if children would be subject to more than minimal risk research, they would stand to directly benefit from it. And there are procedural ways of testing that. So when as Lisa said earlier, if we are in an emergency situation or an imminent emergency situation, the Secretary of HHS would say so. It can't be just somehow whispered in the ear and kept confidential, and then all rules are, or at least the normal rules are lifted. So that's, I think, we need to be, just clear about that. And then I turn to you for the second part.
Great, thanks. Just one quick comment on the potentially beneficial first part. There has been some work done to define direct benefit and indirect benefit, and another even further out, the more distal benefit, the aspirational benefit. And we can look at that and think about there are some good working definitions of direct benefit, and I think we can come to a place where we agree on what that means. So I do think that that's important for us to think about, consider, and define clearly, because we can potentially benefiting could be anyone, as you described. So the second part, remind me again what the...
The informed consent issue with, you know, especially the
In
reason that they're
right.
together, right? Which is that
Right.
if it's a direct benefit, the likelihood of
So-
consent.
Right. So, in the situation of an event, you know, when we're thinking about, again, we have to separate the fact that we're going to be treating and then doing research. So the treatment consent, we would use an IND here to treat kids with, and that there is direct, or you know, a parent is thinking about treating the exposure. In terms of, you know, the risk and the motivation for the parent to consent, it's clear they want treatment for their child. The risks seem high, they want treatment. In terms of agreeing to do research, that's a different set of considerations for parents. So we would, you know, whether the motivation is higher or lower during an event, for the research piece, you know, one could imagine two really different sets of motivations. Either, you know, all I need is to take care of my child and I don't have time to think about anything else, or this is a situation where we have one opportunity to do something really amazing and I'm going to take it. But in terms of, you know, coercion or, you know, highly motivating parents because of a sense of the, you know, stressful situation around the research, less of an issue than around the treatment. So
Let me just follow up on the treatment
Okay.
part, because that's part of what I'm thinking, which is presumably the treatment IND would be approved not just for people who had certainly been exposed, but you know, potentially could have been exposed or within a zone that could be exposed, right? And so the line between treatment and research becomes a bit blurred there, where you have a number of people who are simply within the direct benefits, you know, purview, but who may not in fact have been exposed. And so I'm just worried about the people who would consent and how you obtain meaningful consent under those circumstances where we can't know for sure. Or is the idea that the treatment IND only applies if there is proven exposure for that individual? I assume not.
no, but I do think it's important to keep. So your point is, who wants to get the vaccine under the IND, the treatment IND, and the treatment IND is exactly for that, for treatment. So if a parent says, I want this treatment for my child, whether you, healthcare professional, think they need it or not, that's not a research-related risk or consent issue. That's a treatment-related consent issue. A parent could still say, I don't care if my, you know, it doesn't matter if my child was exposed or not, I want them to participate in the research and face whatever risks I'm willing to allow them to face. But for the treatment piece, it's like a parent going to the, you know, pediatrician and insisting on antibiotics when they have a viral infection. I mean, it's the same kind of, you know, I want this no matter what. The treatment doesn't have to, I mean, it doesn't really have to do with whether they accept risk or not. It's treatment separate from whether they want to enroll in a research project that's going to benefit someone other than their child. So the risks one takes on for treatment is risks for themselves, often because there's lots of benefit to be had. The risk one takes on in research is risks for others, often because there aren't benefits for oneself.
Dan?
Yeah, I just wanted to also caution us to be careful not to go too far in the direction with our language about direct benefit, of assuring that we know that there is going to be benefit. Otherwise, we're, you know, engaging. There's no reason to do the research, and we're slipping over into the therapeutic misconception. So that we want to say that I think we do want to say that there is a reasonable prospect of direct benefit.
Yeah, great point, and I think that language is really important. We must say prospect for direct benefit, because if we knew, we wouldn't need to be doing the research, but well taken, thanks.
Christine?
I think it's true that in the in the post-event setting, the treatment IND and the research IND would be coupled in a way that some of the same kids would be invited to participate in both.
True.
And so the consent process is going to be very complicated, because in that setting, one will have to be able to explain to a parent the difference between receiving the offered MCM and participating in research. But I think it's also true that a treatment IND requires written consent in every case, right?
That is true, and it is much more like the research paradigm, consent paradigm, than it is that's true for the treatment.
Yeah.
Right.
So it is going to be a complicated, practically speaking, situation.
Extremely.
I had one question for Raju, actually. I'm having trouble imagining what you have in mind about procedures that are greater than minimal risk in this setting, in a post-event setting. Are you thinking like liver biopsies or something? I mean, what would be done that might be greater than minimal risk? Because, I mean, the language in the regulations is pretty specific that it's the procedures or the interventions that we're talking about in terms of measuring risk and benefit. And it's so interesting to think about in the post-event setting, if everybody's offered the intervention under a treatment IND, then what research procedure might imaginably fall into a category of greater than minimal risk?
Yeah, for example, lumbar puncture. We talked about that, and it's under normal circumstances that would not be considered to be, routine procedure, and that may be required, right? Or in other cases that I think about, if there is an infectious agent that affects the lung, maybe pleural fusion would be a procedure. Or, liver biopsies, or any of those types of things. It is not possible for us to be able to determine exactly what the nature of those things would be, but certainly there would be a varieties of different types of, procedures or information that you might want to obtain that would absolutely be prohibited under the current set of guidelines for research involving children. But since I have the microphone, can I make just have another comment? At least I wanted to, for us to make sure that we understand this very clearly. Under normal circumstances, an IND, an investigational new drug, if I'm applying for it, they have regular procedures. First of all, you have to do phase 1 trials to be able to really assess the safety, and then phase 2 trials, dose escalation trials to really assess toxicity, and then phase 3 trials that would really involve efficacy.
Right.
In this particular case, we will not be going through all of those different sorts of phases. It is just a mechanism by which the drug at a given dose that would be predetermined would be given basically to patients, right? So this IND that we're talking about is completely different than the INDs that normally would be utilized. And so the kinds of regulations that govern them are completely different. Is that correct?
That was a question? Yes, that's correct. Now, there is the option to do, so that would be the nested, right? That's why they call this nested. You have a treatment or an investigator IND that's going through that. Inside that, you can do the treatment IND that allows access in an emergency situation to do this treatment based on, as you said, a preset, in this case, we likely give children the adult dose because we don't have any other best guess. So there is an option to do a kind of a parallel, a treatment IND in which we would, make a best guess, a different guess, maybe not a best guess, a different guess for dosing for kids. Maybe we say, well, maybe they should have half the dose. But, it's extremely difficult to justify ethically messing around with dose and not knowing what dose to give in the middle of an attack. Who's going to do that or think that's a good idea? So, right. I mean, it's possible. It's just not ethically the right thing to do.
Let's keep in mind that I know we're focusing on the immediate aftermath, which will be very stressful if there's enough preparation, not chaotic, but very stressful. But remember that a lot of the research findings that are needed here are over a long period of time. So we shouldn't, while it's true that the most challenging part will be how one begins, most of the research will be over a significant period of time, and as long as the government is able to provide the vaccine and antibiotics in a timely fashion as the stress, gets lower and we overcome the initial reaction. There's going to be a lot of need and time for ongoing research. And I think part of our job is to also make sure we don't lose sight of that, given that we have the time to deliberate. And I saw Christine, and then I have an important question from a member of the
I just wanted
audience.
to comment on Raju's question, because I think, although I could stand to be corrected, that's where anthrax differs from some potentially other MCMs. And I think the reason that we can think about a treatment IND for anthrax vaccine is because there are so many data already in existence for adults. And so the phase 1, 2, 3 that you talked about, that's already occurred for AVA in adults. And so we can do a treatment IND. In another case where we didn't have so much data, it might not be possible to do a treatment IND, I think.
Mary Coombs, Miami School of Law. Mary, where are you? Welcome, and thank you for this question. Mary, as you point out, pre-event MCM may, and we hope, produce research results that will never be used. However, it is clear that if an event happens and we're less prepared than we could have been, there is likely to be a severe loss of confidence by the public in the government's ability and willingness to protect the public, which has significant public health risks. Can this risk be considered at the margins ethically? Perhaps, and this is, I think, the question and suggestion, actually, perhaps so we don't narrow minimal risk because an event may never happen. So basically, this is a recommendation to us not to overly narrow the understanding of minimal risk. Who would like to? Somebody should respond on behalf of the commission, or at least on your own behalf. Yes.
I agree with that view, and I think that is some of the view that some of the commissioners expressed, today. That the fact that we may not know whether this event is going to happen or not going to happen should not diminish the importance of obtaining as much information as we can obtain, prior to the event. That would really help us. So I'm completely in agreement with this.
I think our recommendation, which we have discussed earlier, and we haven't yet issued it, but we've discussed it, which could begin as we speak if the government wanted to, is to do an age de-escalation, beginning by looking at what the data are, and if necessary, do more research on young adults, and begin with a age de-escalation on the oldest children, if you will. So if you looked at 18 to 24-year-olds and then, or 19 to 24-year-olds, and then inferred minimal risk to 16 to 18-year-olds, or again, there are data there for adults, but they haven't been yet analyzed in a way that would suggest the possibility of proposing a protocol, bringing it before an IRB, and doing what can be done at minimal risk right now. And that's something that we have discussed earlier, and as of now, I think we're prepared to recommend that. Dan?
Just a point of clarification about that. Some of our discussions have led me to believe we might be recommending that even if we're determined to be minimal risk research, we should do age de-escalation within that. And I think that if that were the case, that would be too restrictive. What I think we need to be clear about, which I think what we're saying, is that by doing age de-escalation protocols, we turn what would be, by definition, because of the uncertainty, more than minimal risk research into minimal risk. And I think we've got to be very clear about that.
That's absolutely right. I mean, we have been focusing, because we've done so much focus on pre-event, on post-event, but what Dan said is absolutely right. The reason for age de-escalation is because as of now, we cannot have confidence, and we've been told, we have not confidence that there could be minimal risk research on all age groups. Indeed, we have been told that that is not the case. And therefore, it would take an age de-escalation set of research procedures to do that. You made a narrower point, which is don't make minimal risk research, don't define minimal in an unrealistically narrow way, or an overly narrow way, which is a point well taken. The larger point that we have to do is we have to give examples of what minimal risk research is, and we have to avoid the Scylla of over-narrowingly, making it too narrow, and the Charybdis of expanding it so it is no longer a meaningful protection for children. It must be a meaningful protection, particularly in the case of children who do not directly benefit from the research. I have Christine and Nita.
This is an issue that I think we need to discuss a little further, because I have trouble with the concept of being able to make something minimal risk research. I mean, I think more research gives us more data, allows us to identify the risks, allows us to categorize them, and allows us to determine whether they're acceptable in some way. But it doesn't necessarily make them minimal if they're not minimal. And so somehow we have to be careful about the wording we use in terms of what we're trying to do in more data.
Fair point. That was
But we can discuss
infelicit. Yeah. We weren't making it. We were determining whether there can be minimal risk research. That's important, right?
One more point.
Go ahead.
Think perhaps, I don't know if we fully discussed this, but perhaps if there's a very careful and method of determining what the risks are in older children and first young adults, then older children working down, it might even be true that the risks are acceptable even if they're not minimal. And that's something we haven't really discussed.
I just wanted to highlight a slightly different part of the point that was made, or the question that was made, which was the importance of public engagement and the importance of public confidence in what happens. So one part of the framework that we haven't talked about today, but that we have talked about in previous meetings, is how essential it is in this research, both pre-event and post-event, to start with community engagement, so that at each stage of it, it isn't something where if there is an event that the public and their perception of the government is that it's a failing, rather than an understanding and an engagement in the process throughout, from now till an event, in the unfortunate case where that could happen, and everything that follows. So I think there was a different point that's in there that's just worth highlighting and shows the importance in our framework of really fleshing that out as to what we mean and how important it is from now, as soon as things happen from today going forward, that there's community engagement in the process itself and community buy-in in the process that happens.
Good, really important point. Any other comments or questions before? Lonnie, yes.
Christine, were you talking about post-event scenarios or pre-event scenarios when you're talking about acceptable risk as opposed to minimal risk? I
didn't specify.
You didn't?
I mean, I think that, minimal risk has a regulatory definition, and it's controversial, and people disagree about what falls under that rubric. But I think we've been talking about, I guess, more in the context of pre-event studies, doing enough research that we can, and I think the word make minimal has crept in there a little bit, make it minimal, and that doesn't make sense to me. So it seems like, the more research you do, the more you know what the risks are and can decide whether they're acceptable or not.
Yes. In fact, can I follow up on
Yeah.
clarification? No, you can keep your microphone on because I want to hear from you on this. I think you're precisely right, and I think everyone agrees that we're not talking about making something minimal, but one could determine whether or not it's minimal. Where I was confused was the way you use the word acceptable risk, because my understanding has been that this has been all about acceptable risk, and that minimal risk is acceptable in one circumstance, and some increment above minimal risk may be acceptable in other circumstances. But acceptable is what we have been talking about all along, and that's how I've understood it.
I guess I am not 100% sure that I think we have to limit pre-event testing to only minimal risk.
For it to be acceptable.
Yeah.
We better talk about
And
that.
I don't
because
know
I
if
think
that's what
where
the
we're- that's where we
commenter
are.
was raising either, that,
Yeah.
to say no pre-event research unless it's minimal risk is a pretty strong statement.
I think that's where we are now, so we ought to talk about that.
On the question of making, take making out if you want, it is designing protocols that would minimize risk, okay? And that's what the...
Well, I absolutely agree with that.
It's a different, for example, we now know as best we can, and most knowledge is within, at most, a 90% confidence interval. There isn't, we now know that if we went ahead, we are told, and we have to accept by experts, that if research went ahead with young children, it would be more than a minor increment over minimal risk, and that is unacceptable.
Right.
And
can I say something about that?
yes,
Maybe.
of course.
Depends what I'm going to say.
No. My sentence was in the middle, but that's okay. You're welcome to interrupt me.
My understanding of that determination was because there are no data in little kids. And so the idea of collecting data in incremental way to determine, how we can predict whether it's more than minimal risk or more than a minor increase over minimal risk, all of that makes sense to me. And I also think it's very important that it does make sense that we could find ways in incremental research to minimize risk. But that's still different than whether or not it ends up being minimal by most people's lights.
Correct. And remember, we are talking about pre-event research on children who do not stand to directly benefit from it for a totally indeterminate risk. So it is really important to its ethical acceptability to maintain that at minimal risk. Now, there's minor increment over minimal risk. Again, it depends on how one defines it, but that's at the upward bound, no significant threat to the health or well-being of children.
So then that's minimal, not by its regulatory definition.
Well, we have to get in the report, we're going to have to get into the regulatory definition, but I am not proposing to change the regulatory definition of minimal risk, especially in a situation where children do not stand to benefit directly and there is no we cannot know what the probabilities of an attack or incident are. And the government is not urging us to do, has not urged us to issue this report quickly, so there is no sense of imminence here. I think it would be, I will just go on record, I think it would be a significant mistake of this commission, to which I would not be party, to open the door to expanding the risks that children can be subject to in research in a circumstance where they do not stand to directly benefit and there is not an imminent risk, an imminent threat, excuse me, an imminent threat. Dan.
Yeah, I think I was perhaps responsible for introducing the infelicitous term use, so or make. I think what I would say is, I think along the lines of what you were saying, Christine, that the ideal that we would have would be by doing dose escalation or age de-escalation, that because by definition, if we don't have any information, it's more than a minor increase over minimal risk, that our hope would be that by discovering that the risk is low in an older age group, that we would, on the basis of that information, be able to determine that the next increment would be a minimal risk study. I mean, that would be the aspiration. That still does leave open the question, what if it happened that it was more a minor increase over minimal risk? Would we still allow it to go forward? Like you, I'm not prepared to say that I would absolutely rule out a sort of a minor increase over minimal risk as precluding a pre-event study, even if it were done in the safest way with age de-escalation. But I certainly don't want to go to the level of saying we would allow healthy children to undergo liver biopsies or have a significant risk of losing limbs, et cetera, in those kinds of studies.
So I think the flexibility in our discussions on this point is probably given by the definition of imminence or high-level threat, and using Alex is probably the way he thinks. I think that gives us the ability to have a pluripotent response to look at, in a situation of imminence, if a United States government leader were to declare that there is an imminent threat, then that would allow a different approach to pre-event research that we've already discussed this. And I think where some of us are coming into sort of scratching our heads like this. I mean, I'm an HIV vaccine researcher, and we had panel discussions of plenty of pediatric vaccine researchers, and this stuff is done. We do vaccine research in children all the time, but the difference here is that if the government is in a position to not be able to tell us that the risk of an attack, and then therefore the benefit to exposed children, in this case exposure to research, can't be defined, and therefore we just have to assign it as 0, then I think that provides one ethical bright line. I think that in a post-event, we've had lots of discussion this morning about that. I think where you have the link between them is that if the government were to then say, well, actually the risk is higher at this point in time, I think that would open the door then to consider pre-event research in children with a minor increment over greater than minimal risk. So basically pushing it into the post-event column. I'm going to adjourn for lunch because we have to reconvene at 1 o'clock. So we will reconvene at 1 o'clock promptly. Thank you all very much.